So I am a pathologist by core profession. I work at Tata Memorial Center in Mumbai and Navi Mumbai. But I also run a computational pathology or a AI lab where we build our own models, we validate other people's models, and we are trying to push a lot of these models into clinical practice. Uh, and To do that, obviously, I don't do it alone. I have a team of engineers as well as technicians, scientists, both within TMC and ACTREC, as well as in IIT Bombay, who help us do all of that. So today's talk is basically I'm going to give you an overview of where AI ML is going in pathology specifically, but more generally in oncology, and how we are working to bring all of that into clinical practice. So as an oncologist, as a pathologist, I most of the diagnosis in cancer, most of the treatment in cancer is driven by tissue examination of the cancer biopsies or any surgical excisions that happen. And over time, the amount of investigation that we do on the tissues have increased dramatically. Previously, we used to do only naked eye examination, then we started doing microscopic examination around 50 years back. And then the immunohistochemistry revolution came in 1980s and 70s, and then the genomic revolution came in 1990s and 2000s. Then a lot of digital revolution came in the early middle of 2015 and 2020. And now there is an AI revolution that is happening. Now all of these tests take a lot of time, effort, money. And what is happening is that we do all of these tests because we want more and more information from the tissue. We want to give patient better care. We want to be able to tell which patient will respond to what treatment, what are the chances that this patient has an aggressive disease or needs additional treatment and things like that. But to do all of this, there is a lot of tests that are required. And due to this, a lot of the turnaround times are increasing. The costs are increasing in terms of money, effort, as well as the time it takes to do all of these tests. If you look at any of the NGS tests that are now available, they take a minimum turnaround time of 2 weeks. And it is very well known that the response to therapy and our final outcomes actually change based on how quickly the treatment is initiated. So to do all of that, this is where the AI algorithms are coming as a major way in which we can reduce these turnaround times and still get the same or better accuracy in terms of the diagnostic and prognostic information. There are now AI models which can do a lot of the things that I mentioned on the left. They are models which can do diagnosis. We can do a lot of protein expression prediction, outcome prediction. But the ultimate aim of doing all of this is to improve the cancer care and the patient care that we offer in a timely, accurate, and precise, at the same time, it being affordable. Models often can simply do these kind of tumor classifications very easily nowadays, and they often perform much better than pathologists. So if you see this graph, you can see that the dots actually show the model performance. The model actually performed better than the most expert pathologists, and the accuracy levels were significantly high. The left-hand side shows the same thing, that the blue line indicates the accuracy of the model versus the red dots showing the accuracy of experienced pathologists versus those of the students in blue. So you can see that the models essentially are surpassing human capabilities in terms of what they do. We can also do a lot of tumor detection. It's a labor-intensive task. We look at, for every patient that undergoes a surgery, we often look at 50 lymph nodes, 50 slides showing nodes, and then it takes a lot of effort to go through those nodes. It takes time. There can be misses. And the models can actually look at those images automatically and give us where the tumor is and highlight the tumor with 95% positive predictive value and 80% negative predictive values. I've told you about the protein. The most popular and the most widely known is the HER2 protein expression, which is used as a treatment indicator for breast cancer. If it is positive, we give special treatments to those patients. And all of this can be automatically measured on the slides, on the glass slides and the digitized slides. But more so, we can now measure and predict their expression without actually doing the test. For example, in this case, the pink and blue slides, the images that you see are the HNE slide, which we normally prepare, and the brown is the actual IHC test. But in this, we have actually been able to build a model which can predict protein expression directly on the HNE slide by simply looking at the tumor cells and looking at the features of the nuclei and the cellular counterparts. Not just proteins, we can even actually predict genomic mutations. So for example, in thyroid cancer, BRAF mutation is important because it predicts invasiveness of tumor and a worse prognosis. And we actually could build a model using semi-supervised learning, where we could predict the presence of BRAF mutation in thyroid cancer patients with 99% accuracy. More so, because of the semi-supervised method, we could actually draw heat maps onto the tumor, and we could actually see, and a pathologist could see that this, the model is seeing correctly, the model is seeing some features which are otherwise known to be associated with BRAF positivity. Similar to that, we are looking at viral infections in tumors. So this is also, previously there's a test which called P16 test, where it has come from the Western population, where the positive predictive value in the Western population is 90%. But in Indian population, because of the lower prevalence of HPV, the positive predictive value is not greater than 50%. And our DL test actually performs much better in terms of detecting HPV infection in this oropharyngeal cancer, because it is a prognostic as well as therapeutic predictor. We decide the treatment based on these markers. More complex genomic AI-based algorithms are also possible, which can now predict not just a single protein, but also entire proteome predictions are possible. So mRNA sequencing and NGS sequencing data results can be replicated using simple deep learning models that work on the HNE standard pathology slides. This is another example where standard pathology slide is used to predict which tumor is aggressive and therefore requires additional treatment. And this again runs very fast on a HNE slide, and we can give a result in less than a day's time. So as you see, all of these AI models are now possible to predict outcomes, etc. Similar for cancer recurrence prediction in prostate cancer. This is an example. But why do you not see all of this in the treatment actual outcomes? Because although the technology is quite advanced, the adoption in the medical community is not so advanced as yet. Medical decisions taking is another ballgame. So this is the entire AI life cycle. Most of the results that we show and are available in the media cover only the engineering part of it. The clinical testing and deployment part of it is not shown. Moreover, there are a lot of hurdles in the adoption of this thing because the data volumes are large, and inter-hospital and inter-laboratory variations, and the models may not be able to generalize. So this is how we usually do. We actually convert the glass slide into tissue slide and onto a digital slide, and this particular file format is generated. If you look at the file, we can actually go about the entire tissue on the computer instead of looking at under the microscope. But the problem is that these are two huge files, so there's a lot of IT infrastructure required. If we digitize the data in TMH, then it is roughly 1 petabyte per year. And the models don't perform equally well everywhere. Let me just jump to a few things that are important that show what we have been doing in addition to what I've already shown. Now, to overcome all of this, we need a lot of data. This is a particular multi-institutional project that we are at Tata Memorial Center, AIIMS, New Delhi, PGI, and Rajiv Gandhi Cancer Hospital, along with IIT Bombay. We're putting in a lot of data from patients, the slides, their clinical information, and this data is going to be available for AI researchers in the immediate short term. In summary, the AI technology is mature, but medical adoption in the medical community is not. There are a lot of issues in adopting all of this in the hospitals and laboratory sector. Having said that, it is still years before all of these tools will be available very quickly. Some of these already are, but not widely used. We have to remember it is not a total replacement for existing methods, but they add to the armamentarium of the oncologists and the doctors to give patients better medical care. Few acknowledgements of my entire team at TMC and outside TMC, and the engineers and etc. who work with us to do all of this. This is my organization, primarily based out of New Bombay and at TMH in Parel. Thank you. Thanks a lot.